You know that feeling, right? When you're
Right.
trying to get your head around a medical topic, maybe something about blood clots, and
Mm-hmm.
suddenly you're just wading through pages and pages, it feels overwhelming.
Yeah, information overload is definitely a thing.
Well, consider this our focused chat to help cut through some of that noise. Today, we're taking a deep dive into thrombophilia.
Okay.
Think of this as your streamlined guide. What it is, why it matters.
Exactly. Our mission here is really to pull out the key insights about thrombophilia from the notes we have. Make it clear, easy to remember.
Like audio flashcards.
Sort of, yeah,
Yeah.
basically to simplify it for revision.
And we're looking specifically at revision-style notes on thrombophilia, so it's pretty targeted information.
That's right.
So if you've ever felt a bit lost in the details about clotting disorders, you're definitely in the right place. Let's unpack this together.
A to Z.
Okay, so first things first. In simple terms, what is thrombophilia?
Right. At its heart, thrombophilia is basically an increased tendency for your body to form abnormal blood clots. Thrombosis, you know.
Okay, an increased tendency.
Yeah, and the key thing to grasp is that this risk comes from a disruption in the body's coagulation system.
A clotting system.
Exactly. Think of it like a finely balanced scale. Normally, it keeps blood flowing, but can tip quickly to form a clot when needed, like a cut.
Mm-hmm.
In thrombophilia, that scale is sort of stuck, tilted towards clotting.
Ah, okay. So more chance of clots forming where they shouldn't, like in veins or arteries.
Precisely.
So it's like the body's clotting mechanism is a bit overenthusiastic.
That's a good way to put it. Too eager. Yeah,
Is there a quick way to remember that definition? A mnemonic, maybe?
definitely. You can remember thrombophilia by thinking loving thrombosis.
Loving thrombo.
Yeah, like an overactive clotting system that's a bit too keen on making clots.
Okay, loving thrombosis. I like that. It sticks. So what causes this love of clots? Where does thrombophilia come from?
Good question. Fundamentally, the origins fall into two main buckets. Genetic, meaning you're born with it,
Right.
or acquired, meaning it develops later in life because of other factors.
Okay, let's tackle genetic first.
Yeah.
What are some common things there?
Well, the most common inherited causes involve specific gene mutations. You probably heard of Factor V Leiden
Factor V Leiden.
and the Prothrombin gene mutation. Those are the big two.
Okay.
Then there are less common, but still important, inherited issues like deficiencies in the body's natural clot inhibitors. Things like antithrombin, protein C, and protein S.
Right, the natural anticoagulants.
Exactly. And sometimes you'll hear the term heritable thrombophilia used to cover all of these inherited types.
Got it. And the acquired causes. What kind of things can lead to someone developing it?
Acquired causes are much more varied. It can be linked to things like pregnancy, certain hormonal therapies.
Like the pill or HRT?
Exactly. Also, underlying conditions like cancer or autoimmune diseases, especially antiphospholipid syndrome, that's a big one for acquired risk. And even things like being immobile for long periods, having major surgery, or conditions where your body just makes more clotting factors.
So summarizing them.
Yeah,
It's either something in your genes or something that happens to you or develops during your life.
that's the core distinction. Yeah, genetic or acquired.
That helps clarify.
Yeah.
Now, are there specific red flags?
Yeah.
Things that make doctors suspect thrombophilia or worry about clot risk?
Absolutely. There are general indicators we look for. A personal history of blood clots is obviously a big one.
Especially if they were unprovoked, maybe, or happened young.
Exactly. Unprovoked, young age, key flags. Also, a strong family history of clots.
Makes sense.
And for women, things like recurrent miscarriages or unexplained fetal loss later in pregnancy can be important clues too.
And how do those specific causes we mentioned, like obesity or smoking, fit into the risk picture?
Well, they often overlap directly with the acquired causes. So obesity, smoking, using certain hormones, they all increase risk. Same goes for prolonged immobility, like after an operation or having other medical conditions. You see the link back to etiology.
Yeah, the acquired causes often are the risk factors in a way.
Pretty much, yeah. They contribute to that tendency.
Okay, so we've got a good handle on what it is, the causes, the risks. Let's dig a bit deeper into the how. How does this tendency actually lead to clots forming?
Right, the pathophysiology. At its core, it's about that coagulation system being out of balance.
That scale metaphor again.
Exactly. Whether it's a genetic mutation making a clotting factor work too much or an acquired condition interfering with the inhibitors,
Right.
the balance is tipped
Towards clotting.
towards clotting. And the result is just, well, an increased tendency for clots to form when maybe they shouldn't.
And the potential bad outcomes. What can actually happen?
Unfortunately, the consequences can be serious. You can get a deep vein thrombosis, a DVT, usually in the legs.
Swelling, pain, redness.
Yep, the classic signs. Or more dangerous, a pulmonary embolism, a PE, if that clot travels to the lungs.
Shortness of breath, chest pain.
Right. And if a clot blocks blood flow to the brain, that's a stroke. Clots can happen elsewhere too.
And the exact mechanism can vary.
Yes, depending on the specific type of thrombophilia. It might be the clotting factors themselves, or issues with platelets, or even problems with the lining of the blood vessels, the endothelium.
Okay. So if someone presents with a clot, how do doctors figure out if thrombophilia is the root cause or if it's something else? What else is on the differential list?
Good point. Considering the differential diagnosis is crucial. You need to rule out other things that increase clot risk.
Like what?
Well, antiphospholipid syndrome, which we mentioned that's an acquired condition but needs specific consideration. We also need to think about those specific deficiencies in natural anticoagulants, antithrombin, protein C, protein S, to pinpoint the exact issue.
Right, back to the causes again.
Exactly. And also other acquired conditions that might increase clotting factors, like certain cancers, for instance.
And what about those temporary risks, like surgery or pregnancy? How do they fit in when diagnosing?
That's a vital distinction. Thrombophilia is an ongoing predisposition.
Right.
Things like surgery or pregnancy definitely increase clot risk temporarily, but they aren't usually the underlying condition causing persistent risk in the way thrombophilia is.
But they could trigger a clot in someone with thrombophilia.
Absolutely. They can significantly amplify the underlying risk for someone who already has thrombophilia.
Okay, let's zoom out slightly. How common is this?
Yeah.
What's the epidemiology, say, in the UK?
Well, it varies. It really depends on which specific type you're talking about.
Okay.
For inherited thrombophilia overall, the estimate is maybe around 1 to 5% of the general UK population might have one.
1 to 5%. That seems quite wide.
It is, because the different genetic mutations have different frequencies, you see. Factor V Leiden is more common than, say, antithrombin deficiency.
Right. And acquired.
Acquired thrombophilia is even harder to pin down with a single number. It's so linked to other things, age, sex, other medical conditions people have.
Comorbidities.
Exactly. So giving an exact overall prevalence is tricky.
Okay, so what actual signs and symptoms might make a doctor think, could this be thrombophilia? What might you see?
Often it's the classic signs of a clot we just discussed. DVT symptoms, the swelling, pain, warmth, redness, usually in a leg, or PE symptoms, sudden breathlessness, chest pain, maybe palpitations.
Right.
And as we said, for women, recurrent miscarriages or unexplained late fetal loss, plus that personal or strong family history, especially clots at a young age or without a clear trigger.
Are there any less common ways it might show up? Unusual presentations?
Yes, definitely. Sometimes clots happen in really unusual places,
Like where?
like the mesenteric veins in the gut, or the portal vein going to the liver, or even the big sinuses in the brain, like the sagittal sinus.
Wow, okay.
Also, getting multiple clots in different places around the same time, that's a red flag.
Mm-hmm.
In newborns, there's a very serious condition called neonatal purpura fulminans, widespread purple skin patches, due to clots that can link to severe underlying thrombophilia. And rarely, a nasty reaction to warfarin called warfarin-induced skin necrosis can be a clue, particularly if someone has a protein C or S deficiency.
Okay, quite a range there. So if thrombophilia is suspected, what investigations are typically done?
Well, the first step is always taking a really detailed history, personal and family history, especially focusing on any previous VTEs, DVT, or PE and what might have triggered them.
Right, the context.
Exactly. Then it's about selective testing. It's really important to stress this. We don't just screen everyone who has a clot.
Not universal screening.
No, absolutely not. It's based on the history and clinical picture. And crucially, timing matters.
Oh, so?
It's usually best not to test during the acute clot itself or when someone's just started anticoagulation.
Why is that?
Because those situations can mess with the test results, and honestly, the results usually won't change the immediate management of the acute clot anyway.
Okay, so timing is key. When should testing for heritable types be considered then? Are there guidelines?
Yes, the British Committee for Standards in Hematology, BCSH, gives specific guidance. They say testing is usually required in a few situations.
Okay, like what?
Pregnant women with a previous VTE that wasn't linked to estrogen and only had minor risks, newborns or kids with that purpura fulminans,
Right.
and adults who get severe warfarin-induced skin necrosis.
So quite specific, severe scenarios.
Generally, yes. Then there are situations where testing can be considered.
Considered, but not essential.
Right, like VTE patients with a really strong family history of unprovoked recurrent clots, or asymptomatic relatives and families known to have high-risk thrombophilia, what we call case finding. Also, maybe female relatives considering estrogen contraception or HRT if there's known high-risk thrombophilia in the family, and patients who've had a clot in a cerebral vein, a sinus thrombosis.
Okay. And when is testing generally not needed?
Yeah, there's quite a list here, too. Generally not for a first VTE episode without other strong features. Not usually for routine hospital VTE risk assessment. Not usually for asymptomatic relatives of low-risk cases. Not typically needed just to decide on standard contraception or HRT for relatives of VTE patients without other flags.
Okay.
And generally not for unselected cases of clots in the upper limb, catheter-related clots, retinal vein clots, after IVF, arterial clots like heart attacks or strokes or childhood stroke.
So lots of situations where it's not routinely done. What about clots in the abdomen?
Yeah, the guidance suggests the role of testing for intra-abdominal vein thrombosis is still a bit uncertain.
Okay, those guidelines are really specific. What are the key take-homes if testing is done?
Several crucial points. As we said, avoid testing acutely. It doesn't change immediate care.
Right.
Interpreting the results is complex. You can get false positives, false negatives. It needs specialist lab work and, really importantly, expert interpretation by clinicians who know thrombophilia well.
So not straightforward.
Not at all, which is why pretest counseling is so important, explaining the implications and getting specialist input on the results.
Makes sense. What are the initial blood tests usually ordered then?
The initial screen usually includes a full blood count, looking at a blood film, basic clotting tests like PT and APTT, then the specific assays for antiphospholipid antibodies, and the common heritable markers, Factor V Leiden, Prothrombin G2210A, and testing protein C, protein S, and antithrombin levels and function.
Okay, that's the core panel. Are there other more specialized tests sometimes needed?
Yes, depending on the whole clinical picture, you might look at inflammatory markers like ESR, CRP, maybe ANA for autoimmune issues.
Right.
A deeper clotting screen could check fibrinogen, other factors like factor VIII, plasminogen, factor XII. Homocysteine might be relevant sometimes.
Okay.
And depending on the person, you might investigate for underlying heart, liver, kidney problems, or even screen for hidden cancer, as these can sometimes cause acquired issues.
Wow.
And in families with a very strong clotting history, you might even test for rare things like dysfibrinogenemia.
So the bottom line is really target individualized testing.
Absolutely. It's definitely not a one-size-fits-all approach.
Okay, so let's say someone is diagnosed. What happens next? How is thrombophilia managed?
Right, management. The main goal is simple: prevent or reduce clot formation and avoid complications.
Right.
But the approach has to be tailored. It depends heavily on the specific type of thrombophilia, the person's other risk factors, their overall situation.
Right, individualized again.
Exactly. Options can include lifestyle changes, weight management, stopping smoking. Anticoagulant medications are key warfarin, or the newer DOACs.
Blood thinners.
Yep. And specific preventative measures might be needed during high-risk times, like around surgery or during pregnancy. And ongoing monitoring is vital to check treatment effectiveness and safety.
What general advice do people with thrombophilia usually get for everyday life?
Education is really number one. Understanding their condition, the risks, the symptoms of a clot.
Being informed?
Absolutely. Staying mobile, staying hydrated, basic but important. Being extra careful during high-risk times, long travel, illness, surgery, pregnancy. And for women, generally avoiding estrogen-containing contraception and HRT. Progestogen-only options are usually advised, and definitely pre-pregnancy counseling if planning a family.
Right, to make a plan.
Exactly.
What about using medications specifically to prevent clots thromboprophylaxis? When does that come into play?
Good question. Thromboprophylaxis might be short-term or long-term.
Okay.
For someone with known thrombophilia or a previous VTE, short-term anticoagulation might be used during high-risk periods like post-op. For a first unprovoked VTE, long-term anticoagulation isn't usually recommended just because someone has most types of thrombophilia.
Right.
But if someone's had 2 or more unprovoked VTEs, indefinite anticoagulation might well be considered.
Okay.
Prophylaxis might also be used during high-risk times for people with recurrent VTEs linked to triggers, and sometimes short-term cover during high-risk periods for asymptomatic family members with a known high-risk genotype.
It's complex deciding who needs long-term treatment.
It really is balancing risks.
And what about pregnancy and afterbirth? You mentioned that's high risk.
Yes, a really critical time.
Yeah.
Pregnancy and the postpartum period naturally increase VTE risk for everyone.
Right.
And that risk is magnified in women with thrombophilia. There are specific, detailed RCOG guidelines for managing this.
Royal College of Obstetricians and Gynecologists.
That's the one. Their guidelines cover risk assessment and reduction strategies tailored for different thrombophilias during pregnancy and after birth. Following those is crucial for mom and baby's safety.
Okay, really important area. So, looking long term, what's the prognosis generally like for someone with thrombophilia?
It's highly variable. That's the main message. It really depends on the specific type, other risk factors, and importantly, how well it's managed.
So management makes a difference.
Oh, absolutely. Appropriate treatment and lifestyle changes can significantly reduce the risk of clots, but individual risk varies a lot.
What influences that variation?
Things like family history, whether they've had a previous VTE, if they happen to have more than one type of thrombophilia, and other coexisting conditions or lifestyle factors. Certain combinations really ramp up the risk, like being homozygous for Factor V Leiden and taking estrogen, for example.
Oh, yeah.
And again, interpreting the test results in context is key, and always balancing that thrombosis risk against the risks of bleeding from long-term anticoagulation.
It's a constant balancing act.
It really is.
And what are the potential complications we're trying to avoid?
Well, the primary concern is obviously more thrombotic events, the BT, PE, stroke, clots, elsewhere.
Which can be serious.
Very serious. They can cause significant morbidity, long-term problems, even mortality. The risk of recurrence is also a major issue, impacting quality of life and often meaning long-term treatment.
Mm-hmm.
Then there are the pregnancy-related complications we touched on, especially with APS and some heritable types, preeclampsia, issues with the placenta, pregnancy loss,
Right.
and that rare but nasty warfarin-induced skin necrosis and protein C or S deficiency. There's also some maybe limited evidence suggesting a possible link to arterial clots, heart attacks, strokes, but that's less clear-cut for many types.
Interesting.
And finally, don't underestimate the psychological impact. Getting tested, getting a diagnosis, it can cause a lot of anxiety.
Yeah, I can imagine. Okay, so to sort of wrap up our deep dive, what's the main message you'd want listeners to take away?
I think the key thing is that thrombophilia is complex, definitely. Lots of different causes, varying risks. But getting a solid handle on the fundamentals, the definition, causes, diagnosis, management principles is just crucial for good clinical practice and for anyone revising this area.
And remember the mnemonic.
Yes, thrombophilia loving thrombosis, that overactive clotting system.
Perfect. Our aim here was really just to give you that clear, digestible overview, help navigate through the information.
And hopefully make revision a bit easier.
Exactly. Hope we've managed that for you.
We certainly hope so. And, if this has sparked interest, there are loads of great resources out there to learn more.
Absolutely. And on that note, a final thought maybe. Considering all these different factors influencing clotting, makes you wonder what other seemingly unrelated conditions might have subtle links to thrombotic risk, doesn't it?
That's a great question. Definitely food for thought and an area of ongoing research.
Indeed. Well, we hope this deep dive has helped you unpack thrombophilia. For more resources to support your MSRA preparation, do check out PassTheMSRA.com.
And freemsra.com as well.